Hello, everybody. Hello, Dr. Zac. Welcome,
Everybody.
welcome. I'm just letting more people in, and I'm going to open the chat. Someone said hello in the chat. Say hello if you
That's
want to say hello. I
Roxanne.
so thrilled that we are doing this for Dysautonomia Awareness Month. I'm so glad you said yes to this, Dr. Zac, because you are a force to be reckoned with in this area. Because there really are not many people advocating for patients like us. So thank you. Hello. Where is everyone from? Type it in the chat. So I'm coming to you from sunny Queensland in Australia. Dr. Zac, where are you located?
I'm in beautiful North Carolina,
Beautiful North
United
Carolina. Is it
States.
starting to get really cold?
No,
Sydney,
it's
Washington, DC.
North Carolina's a pretty warm state. We're still
Okay.
humming at like 60s right now, so we're
Okay,
it's pretty.
lovely.
How
Oh,
about you? What's the temperature like where you are?
it's hot. It's starting to get summery. It's like
Oh yeah.
30, I don't know what 30 degrees is, but it's hitting the hot temps, which is not good for pots. But
Not
we've
yeah.
got we've got America, we've got Australia, we've got Latin America, we've got more Australians, Brazil, amazing. All right,
Great.
well,
Yeah, people from all over the place. This is
yes,
fantastic.
this is so
This is so
wonderful.
cool.
Very
Yeah.
cool. All right, so just a little intro from me, everybody. My name's Kimberly. I'm a naturopath and a clinical nutritionist. I am a mom of three. I am a POTSy. I've had pretty severe POTS for many, many years now, at least 10 years. Um, I have, yes, we're getting great messages. I'm just reading the chat and getting distracted. Love Dr. Zac. We want you to come and lecture in Australia. We certainly do. Anyway, yes, I'm based in Australia. I have POTS. I have undiagnosed EDS and MCAS, but I'm very hypermobile and histamine sensitive. Thankfully, I've had a wonderful care team around me to help support me. I deal with specifically in my practice patients with endometriosis, POTS, MCAS, EDS, and other comorbidities. But today we have the wonderful Dr. Zac with us, and we're going to be talking about all things POTS, MCAS, EDS, and gut issues. So I'm just going to start with letting you guys know that the chat is open. If you do want to ask any questions, make sure that you type your questions in the chat box and we will get I will continue to allow people in, but this is just going to be a very casual, wonderful conversation with Dr. Zac where we get to pick his brain. So I would love to start off with talking about gut issues in dysautonomia. Um, so can you tell us, based on your expertise and your experience, Dr. Zac, why is it that we see so much IBS, SIBO, and motility disorders in patients with dysautonomia or the trifecta?
That's a really good question. How much
It's a
time do we
big
got?
question. Yeah, we have.
Uh, so, it's I think I break this down into kind of two like kind of mutually exclusive but certainly connected pathophysiologies, and in one of which is motility alone. So in dysautonomia, right, inherent in the word dysautonomia is that your autonomic system is not working as well as it should. And our autonomic system, our nervous system, controls everything behind the scenes, from how fast our heart beats to kind of blood flow regulation to shoot like tear production in your eyes to pancreas gland kind of production to kind of sexual function to how fast your GI system moves. So it controls everything that we're not actively paying attention to, which is a kind of our somatic nervous system. Um, and so in dysautonomia, we think of POTS, right? So postural orthostatic tachycardia syndrome, you stand up, blood pools, you get less blood flow to your brain, less blood flow to your heart rate picks up.
Mhm.
But that same kind of issue affects the GI tract as well. So in this specific form of dysautonomia like POTS, when we're talking about, is
Yeah,
there's relatively, or I guess because dysautonomia is this huge topic, right? Like it's
yeah.
just, but if we're talking about kind of the hypermobile crew, the form of dysautonomia that more often than not affects this cohort is POTS. Okay, and in POTS, there is more sympathetic tone than parasympathetic tone. And or sympathetic tone is our fight or flight. Okay,
Yeah.
so that's the heart racing, the anxiety, the insomnia. Um, yeah. And so when you're in relatively overactive sympathetic tone and less parasympathetic tone, which is your rest and digest state, then inherently things tend to move a bit slower. Okay. So that can affect anywhere from our esophagus to our colon. Right.
Hmm.
So sometimes we have people that have difficulty swallowing because their esophagus doesn't move as
Yes.
well. Um, gastroparesis is really, really common, right? And so the stomach doesn't empty as well. And then so you see a lot of, you want to get people get full early. They got a lot of
Yeah.
vomiting. And then that also affects the small intestines as well. And so when the small intestine doesn't work super well, it has a tough time clearing debris and waste from it. So you get buildup of bacteria, which leads to small intestinal bacterial overgrowth.
Yes.
Um, and then kind of the IBS part of things is interesting. So when we talk about IBS,
Mhm.
it's inherent, it's not a very helpful phrase, right? Like it doesn't really describe what's happening. It really just means you have a whole smorgasbord of symptoms, but we can't really
Yeah.
figure out what's going on, right?
Yeah.
But the cardinal symptom of IBS is pain. So IBS is defined by pain. And where does pain come from? We shouldn't really have pain in our intestines. Like that's a pretty unique thing to have. And dysautonomia by itself, like a slow moving intestines, doesn't usually cause pain. But what does cause pain in this specific kind of in this cohort? And that's mast cell activation syndrome.
Yeah.
So what mast cells do is they intensify nerve signaling, which leads to feeling of your intestines. Like your brain doesn't want to feel your bowels. Your brain needs to know if there's a bear chasing you, or if like you need to hit the brakes when you're driving your car. It doesn't want to know about your intestines, but the mast cells kind of they sensitize the nerves in your gut called visceral hypersensitivity,
Yeah.
which leads to this pain. It can also lead to diarrhea. So when I have patients in clinic, one of the first goals that I have is when it pertains to their gut and any issues that they have is this motility? Is this hypersensitivity and potentially mast cell activation, or is this something else? And so those are some of the reasons why people develop such a profound amount of GI symptoms, kind of if they're living with dysautonomia and mast cell activation and hypermobility.
Amazing. Yes. And so would you say that, for example, if someone's on famotidine or someone's asked about Pepsid, long-term use, I
Oh,
believe, yes, absolutely. It could predispose you to SIBO.
are you asking me?
Yes. Yeah. The long-term
Oh,
use of something
no.
like famotidine um,
Mm-mm.
makes you more prone to SIBO.
No, it doesn't, fortunately.
Okay.
So Pepcid it's a pretty lousy reflux medication. So let's talk about like antacids.
Yeah.
There is some people really need them, like
Mhm.
peptic ulcer disease,
Yeah.
really bad esophagitis, peptic strictures, which is really bad strictures in your esophagus. Like there are very clear indications for acid suppression medications. So the really strong ones, like proton pump inhibitors, they're a really, really good tool for people that need it. I totally agree that they are 100% overprescribed, right? They are prescribed unnecessarily all the time.
And
If
these
you
are
have
like
like
your Nexiums that people stay on for decades, right?
Nexium protonics, right?
Yeah.
Those can affect the stomach pH and make it more alkaline or more positive um, for long-term use, and it stays pretty alkaline. Okay, there's a loose association between PPIs and SIBO. It's definitely kind of it's certainly plausible, and I don't rule that out. Pepcid is a pretty crappy medication for your stomach acid. So if you need long-term acid suppression, Pepcid doesn't work very well. In fact, it suffers from something called tachyphylaxis, to where the parietal cells or the cells that secrete acid in your stomach just start to ignore Pepcid after a while. So Pepcid actually does not increase your risk for SIBO. There's no data to support it, and mechanistically doesn't quite make sense either. PPIs, I'm all here for it. Like I think that mechanism totally that can definitely predispose you, and that's why PPI should be used only in the right people.
Mhm.
Um, but no, Pepsid is like the beautiful thing with Pepsid is that it's pretty like it's pretty safe for all intents and purposes. Some people have, idiosyncratic mast cell reactions to it. But outside of that, it's a pretty safe medication.
And how does it act systemically? Because it's going to act systemically, right? If it's not going to be a great stomach acid inhibitor, it's more for the systemic mast cell activity and histamine blockade.
Yeah, yeah, so I mean, I think it probably inhibits mast cells a little bit, but mainly what it does is it blocks histamine. So
Yeah,
mast cells release over 1,300 chemical mediators, and
yeah,
histamine is one of them. And there are histamine receptors everywhere. The brain, the nerves, the gut, the airways, the sinuses, the bladder. And so in a person that has a lot of histamine issues, like not everybody's mast cell is histamine forward. In fact,
mhm,
some people you put them on antihistamines and they feel no better at all. But I have some people that you put them on antihistamines and everything gets better. It's
yeah,
not common, but it does happen. And so it is a nice place to start because it's a rather like risk-free intervention and can have profound benefits. But I always tell people that there's a tremendous amount of randomness here. But yeah, so sorry to answer your point, like it just blocks the histamine receptors all over the body. And there's H1, H2, and H3 receptors.
yeah,
Um, Pepsid blocks is H2 receptors specifically, which is primarily in the cardiovascular system in the gut. And I think it's in the brain as well. H1 receptors are more ubiquitous, and there's H3 receptors, which are a little bit more challenging to block with agents that we have. So really, they just block H2 receptors.
yeah, yes. And in your POTS patient, that can be extremely beneficial when we're talking about cardiovascular function too. Um, we have a question here, Dr. Zach, about the pain that you were describing, that visceral hypersensitivity. And I see that a lot in my patients who have, overlapping histamine mast cell issues and chronic pelvic pain and endometriosis. There's a question from someone asking about low dose naltrexone. Can it help with that type of pain?
Yeah, so LDN's curious. So it's not like a narcotic where like narcotics are pretty good for every kind of pain, right? Or most pains, I should say. Um, LDN is good for inflammatory related pain because well, actually, it does boost natural endorphins, so it can
Yeah.
help for a lot of different kinds of pain. Um, but I think there's a lot of misconceptions in what it can do. It can be good for abdominal pain chronically. I don't find it to be profound, however. I find it to be better for a lot of neuromuscular pain in
Yes.
those who have, and so a lot of like the diffuse joint pains. It almost like feels like an autoimmune condition. Like it almost feels a little lupusy, a little like rheumatoid arthritis-y, but like all the biomarkers are negative, and it's just like they get kind of rashy and they have a lot of joint pains and lower back pain and like brain fog and fatigue. That's where I see LDN like really, really working well.
Mhm.
There is some data that helps with GI motility as well. So in those who are predisposed to SIBO, it can help with that too. But I find that its main benefit, and also you have to figure out like I wouldn't just be like pain LDN, right? It has to be a very
Yeah.
specific. And I find it to be like this kind of inflammatory pain that you can see in mast cell a lot, or in people with hypermobility in mast cell. But it also, yeah, it can have this kind of, it helps with neuroinflammation as well by
Yeah.
modulating the glial cells in our brain, which are kind of these immune cells of the brain. So it can help with like brain fog and fatigue as well. But it is not like
Cure
I don't know,
all. It's been touted as like this cure all,
it's
hasn't it?
not, it's definitely
Yeah.
not. And for
Yeah.
the right person, it's nice. But also like what's tough is that it takes like months to really work.
It does,
And
and I
so
find in the very sensitive types like us, it can also backfire and it can cause worsening insomnia. Just with that blockade of the opioid receptors, it can just cause a little bit too much of the upregulation, and I've seen it drive anxiety. Yeah, it's an interesting one, that's for sure. And to find your low dose, some people do better on ultra low dose, so that's another
nailed it.
thing.
Yeah.
Um,
Yeah, I dose it in the morning versus at nighttime to avoid the vivid dreams. But yeah, there's some people that feel a lot worse on it. And,
yeah.
some people, their mast cells are so twitchy that any adjustment to like the inflammatory landscape of your body drives them a little crazy. So just even like a new addition of a medication can really make people feel worse. So
Oh,
yeah,
yes, for
I mean,
sure. I can
yeah,
definitely relate to that. Um, I would love to ask you about um, vascular compressions, abdominal vascular compressions, because it's an area that is so, I think, under-researched, misdiagnosed, not spoken about enough. And I feel that perhaps in the, EDS, hot C, gut issue cohort, we may have more of this than we realize. What are your thoughts on that?
yeah, 100%. It's very, I think I had two patients today. One called me had her visit from the hospital due to
Yeah.
a compression disorder, but everybody thought it was like an IBS variant. So yes, it's very appropriate because it drives me crazy how much this is dismissed because it's so easy to pick up. It really is. Like these compression syndromes are just, they're
Yeah,
not in,
they're
they're
very
not terribly,
characteristic. And I
yeah,
just
like the
wanted to let
story tells the
everyone
whole story.
know, sorry, I don't mean to interrupt you. I just wanted to
No,
let
we're on the
everyone
same
know
page.
what we're talking about. So you can have blood vessels, large blood vessels in your abdomen that are compressed. For example, there's a compression condition called median arcuate ligament syndrome, where your median arcuate ligament is compressing your celiac artery. So that will significantly impact the blood flow to your gastrointestinal tract. Another one is your superior mesenteric artery. And unfortunately, I have been personally diagnosed with both and have had gut issues for a very, very long time. It then affects, your blood sugar, your appetite, your everything. So yeah, I would love to, hear a little bit more from your perspective, how you manage this, how you manage these cases.
Yeah, so let's talk about malls really quickly. I don't know how in the
Yeah.
weeds you want to get with it, but I think the tricky thing is that the misnomer is that we were taught that it's an ischemic process, that it's the ligament sitting on the artery, but
Yeah.
I don't think it is.
More neurological.
I think it's sitting on the nerve plexus
The
because
cardi, gosh, I'm having, I said
iliac angle.
celiac plexus.
Yeah, because I mean, I've seen dozens of cases where the ultrasound is negative, and then we do. So yeah, so it's the story, and this is like with all of these conditions, the story tells me what's going on. Like
Yeah.
the data points in the space are just reliably unreliable. Gastric emptying studies, endoscopy, CT scans, they're just not very helpful. Biomarkers, not very helpful. So, man, I listen, and
Yeah.
the story is so freaking telling. And so Malls is, man, the story is so unique to it. There's nothing else that behaves this way. And it's as
Yes.
soon as someone eats,
Yeah.
like within seconds,
You
they
feel
get
sick.
horrible pain right under the xiphoid process, and also with drinking liquids too. So
Definitely.
whereas like the way I think of it is like, okay, so if you have mast cell activation syndrome, people can get full early and sort of get pain after eating, but there's usually some safe foods, chicken, rice, and it ebbs and flows. Gastroparesis, it
Mhm.
doesn't usually ebb and flow. It's usually there every day, but it's not usually pain. It's usually you get full early and you can do liquids more so than solids. But malls, it's freaking
Everything.
everything that you put in your stomach and it hurts so bad and there's always weight loss and like just nothing in medicine behaves this way. So that's why it's like within 5 minutes I know if someone has malls or not, right?
Yeah. Yeah.
So I will tell them right off the bat, you have malls. And also they usually have hypermobility in POTS. If they don't have hypermobility in POTS, I'm a little bit less inclined to give this a malls diagnosis right off the bat. But if they live in the trifecta world, I'm pretty quick to be like, you got it.
That's
And
yeah,
so
so characteristic of it. Yeah, those
yeah,
symptoms.
100%. And by the time they've seen me, they've already had all the testing. So you know they don't have an ulcer, they don't have cancer, all the scary stuff. Um, oh, someone said they got acupuncture for their SMA. That's interesting.
Yeah, so I was going to say that I respond very well to thoracic spine manipulation chiropractic because
Amazing.
my ligament is squashing my celiac artery, but if I have a good, there's only one chiro that I trust with all my stuff, and he knows what he's doing. But when you look at the nerves that branch from the thoracic spine and the sympathetics and that celiac plexus, it makes sense as to why it's the only thing that gives me relief. I haven't done a block. But I'm definitely not going for the surgery because I'm not there yet. And I've seen people who've had the ligament release and they're still just as symptomatic.
because they're not doing the right surgery. So the people that I see, they're typically far too gone. Like they've already lost 30, 40 pounds. And
Yeah.
so I'm not sure, maybe chiropractic adjustment would work. We're kind of in a, they're horribly malnourished kind of
Yes.
situation. Plus, I don't know, like it isn't, I do know of people who do like visceral manipulation that say they treat malls and SMA well.
Mhm.
Um, I just don't know those people I don't think those people live near me. And these
Yeah,
people are like,
there are a couple osteopathic doctors here that are doing research on osteopathic visceral manipulation and MALS, which is really exciting to see. Um, Obviously, if you need the surgery, you need the surgery, but there are people who aren't quite there yet that are still dealing with pretty intense symptoms on a
mhm.
day-to-day, meal by meal, drink by drink basis. So yeah, it's interesting. And so what can you tell us a bit more about the SMA?
Yeah, and so just to put a bow on the malls. So yeah, so we make sure people getting enough nutrition because usually people haven't like eaten for weeks when they've seen me.
Yeah,
So I'll put a nasojejunal tube in,
yeah.
unfortunately, which is fun. Feed them, and then we do a block. And if it gets better, then it's kind of diagnostic that you have malls, and then we talk about a surgery. Obviously, if it's and we weigh the risks and the benefits. Um, but I truthfully will only do surgery if it's really, really bad. And people have lost tremendous amounts of weight. And time is of the essence, so to speak.
Yeah.
SMA syndrome. So the most common cause of SMA syndrome is MALS.
Mhm.
So SMA syndrome is where the third part of the duodenum it runs between these two arteries called the superior mesenteric artery and the aorta. So they kind of like they do this thing, and the duodenum runs right through it. And there's this fat pad between the SMA and the aorta, and when you lose a lot of weight, the angle
Yeah.
shrinks, and it can compress the duodenum. And so the most common cause of SMA is malls
Yeah,
around the
because you're
country.
losing the weight and that fatty pad is just getting thinner and thinner and that angle's getting narrower.
Exactly. And so the story is also pretty telling there. So it's also pretty tough to diagnose. Just the imaging can be really there's certain like angles you can look for on the CT scan between like the SMA and the aorta. There's not like a really good functional test like in malls you have the celiac block, which is really nice because it's like, oh
Yeah.
well, if it works, then you benefit from a surgery. It's not as clear cut in SMA, but the story is pretty helpful. So let's think about like what SMA is. So SMA syndrome is so where you're getting compression of the intestines, right, by these arteries, and so you get blockage of food. And so what you'll get kind of pain kind of around the belly button, a couple hours, well, 90 minutes, 120 minutes after eating, but it's usually eating something that is tough to digest, like roughage.
Mhm.
Um, and you'll get maybe some nausea and some emesis as well, because it's really like an obstructive process. That's kind of how it presents. So if it's like pain, if you're having pain without eating or pain immediately after eating, it's probably not SMA. It usually follows this pattern, but not always. I mean, so there's definitely like not everybody's the same. A CAT scan can be suggestive because if you kind of can measure this anger, it's late. Measure this angle between the aorta and the SMA, and if it's less than it's like 17 degrees. It's late. Don't quote me on that one. And you can measure the aorta SMA distance. It's pretty suggestive of it, but you take that in the context of someone's symptoms. And then people order this barium study to see if barium gets hung up there. It's called a small bowel follow through in the States. And you drink barium, see if it goes through your intestines. And there's this thought that like if the barium gets hung up at the intestines, then that's diagnostic. But if like liquid is getting stuck there, like you're so and like you're in the 99th percentile of severity. And so
Yeah,
you kind of have to, you know what I mean? So even if it's normal, you're like, well, just because liquid gets stuck there doesn't
that's
mean
right.
you need salad it doesn't. And so that's why you have to take Jillian just said that her barium got stuck, and so she probably had really, really bad SMA.
Yeah.
But certainly people can have symptomatic SMA without that barium being there or being stuck because yeah, sometimes liquid can fly through, but it's the food. Like if they did a small bowel follow through with like radio opaque kale, like then
Yes.
maybe then it'll get stuck. But yeah, so that's SMA for you. And that's a tough diagnosis. We try to feed you. whether that's like an NJ tube or TPN sometimes to kind of beef up
Yeah.
that fat pad. But if it is due to like if it's idiopathic or just kind of it just happened because of hypermobility, right?
Yeah.
That things just like everything just kind of sags and droops on it, then sometimes you need a surgery. And the surgery is a humongous surgery that is really tough. It's a really tough one.
Yeah. Yeah, I can
But as you
imagine.
said, maybe there's like you can do visceral manipulation, chiropractic adjustments. Like maybe there's other ways to go about it that I'm not aware of.
It would be really good if there were alternatives because of the severity of the recovery itself would wreck someone who's already so depleted.
Yeah.
Um, we've got some amazing questions here. I'm thinking we might just start going through them if that's okay with you.
Sure,
Um,
whatever you want.
yeah, given the gut-brain interaction, what are your thoughts on somatic therapy for sympathetic nervous system regulation, alongside other modalities?
Somatic, are we talking about like cognitive behavioral therapy, hypnosis, things like that? Is
Oh, I'm
that
thinking it's more like there are a lot of things out there in the
Gupta,
space that I work in
DNRS?
around like retraining your brain and somatic therapies
Like,
to downregulate that sympathetic nervous system. I think anything that can downregulate sympathetic
yeah.
drive is great.
Yeah, and I don't I think that when you talk about this world of like brain gut interactions, mast cell activation syndrome, kind of our fight or flight, our stress response is plays such a big role in our symptoms for so many reasons. And so, but what that looks like is different for everybody, right? Like, so there's great data for hypnosis. Some people really like hypnosis. Some people like guided meditation. Some people like cognitive behavioral therapy, where people, some people are like, man, if I don't poop first thing in the morning, my whole day is ruined.
Yeah,
Or if I bloat after eating, like my day is done. Like everybody's going to notice. And those thoughts spiral and cause more anxiety and stress. Some people like this kind of limbic retraining, like
yeah,
DNRS. Yeah. So it's all different ways to find the same thing, right? Which is mindfulness and coping mechanisms when you're really stressed out. And those things don't like meditation doesn't work for me. I've done CBT, doesn't really work for me. I like getting outside and working out. Like that's my way of kind of resetting my nervous system. And everybody has a different way of going about that. So it is such an important thing to talk about.
mhm,
I wouldn't say it's everything because I do find that, you know, that diet plays a role too. And if there's ongoing inflammation, like mast cell activation or motility issues, like it's tough to kind of meditate your way out of that or be mindful like through those symptoms because sometimes you're so in so much discomfort that it's tough. You can't outthink that. I
absolutely.
think in all chronic conditions where there's an element of like coping, it's incredibly important.
Yeah. Yeah. No, you raised a great point there. If you're so inflamed, it makes obviously we're playing into positive neuroplasticity here, right? That's the whole point of all these brain rewiring programs. But if you can downregulate some of that inflammation, that systemic inflammation with diet or um your mast cell stabilizers, whether they be pharmaceutical or non-pharmaceutical, like that's all going to be part of what's going to bring down that sympathetic nervous system um, activation, so to speak.
Yeah.
Um,
One of the first questions I ask is how are you sleeping at night?
yeah,
Because there's really good data to show like your GI symptoms are way worse if the day after you have really lousy sleep. And so you want to work on like the building blocks first, like diet, sleep, are you getting outside? What are you doing for yourself? And what kind of tools, like data-driven tools, do we have that you can look into to help regulate your nervous system, right? And maybe that's just seeing a therapist, maybe it's CBT. There's so many ways to do it, and just got to find the right whatever resonates with you the best.
yeah, and I think, being a patient with complex overlapping conditions myself, we sometimes can get so overwhelmed that we underestimate the effect of the basics, like getting the basics in order, because we're doing complex tests and there's polypharmacy involved and this and that, and we forget about the importance of doing what we can do in terms of getting our sleep right and eating what we can. And I guess that's why I'm passionate about what I do. But yeah, it's so easily overlooked.
Yeah, 100%. 100%. You got to look at all the angles here. But I definitely like, and I'm a doctor, right? And so we use medications a lot. And so I typically will treat pathology first because I do find that it's really, really tough to implement exercise, mindfulness if you're inflamed and feel terrible.
Oh yeah, for sure. You can't.
If you're seeing me in clinic, by nature, you're not feeling great. And I've never had anybody, or I've never felt confident about a plan where like all we did was do limbic retraining or hypnosis. I think it's part of a bigger plan.
For
Um,
sure. I mean, you can't, if you're standing up and your heart rate is doubling, like
you
you're
can't breathe. Yeah.
swinging. Exactly. It's not gonna, nothing's gonna, nothing else is gonna eventuate positive out of that. So, I agree 100%. Um, can I ask you a question about advocating for yourself to a GI team? What do you,
Sure. Tough
yeah, what do
conversation.
you recommend? So this is someone's question. What do you recommend for getting help when doctors focus on the fact that all imaging is normal? I think
Who
we
said
mentioned
who,
there
who
before.
said this question?
Um, Christian has asked this question.
Christian. I have no good answer for you. I'm going to be very honest with you because, and I'll tell you this, I can't convince other doctors to take people seriously,
It's
right?
hard.
Like I I can't. Like I've been in places where I've had patients admitted to the hospital with a really severe thing that they didn't think existed,
Yeah.
like malls. And I'm telling them that this is a real thing. They're like, I think they need a psych consult. I was like, you need to shove it. What are you talking about? You're so I think that, and I want to be honest because man, I mean I know a lot of doctors and I am a doctor and I think people train for a really long time and then they finish training and think like I got this. And when something new comes along that doesn't fit in their paradigm of what they think should happen in someone's body, it's tough for them to reconcile it. And there's two ways of going about this. They reach this crossroads. You can either trust the patient and say, maybe there's something that I don't know. Or you can say, that doesn't fit with what I know about medicine. This must be a psychiatric issue, or this must be anxiety, right? And so, unfortunately, a lot of people fit into the latter category. And because they're like, I'm kind of done. And so sorry, Christian, I know I didn't mean, but I think early on when I did podcasts, I was like, just bring them articles. It's not going to work.
No.
It's not going to. Doctors have 30 minutes in clinic, okay? And I've met a lot of really, really, really good, thoughtful doctors that just like mast cell doesn't make any sense to them. We weren't trained on this stuff. So imagine you do your job, right? Whatever you guys, Christian, you're really, really good at, okay? And then someone comes to you and says, "Hey, you know what you're really, really good at? There's something that you have not heard about that I have. Like, is that possible?" And you can either say, well, maybe there is. I know you don't really have maybe any training here. You kind of read something and but I can either listen to you and be curious about that or say, like, you know what? I kind of know what I'm doing here, right? And you can understand a lot of doctors being like, hey, look, I kind of got this. Like, hey, leave this doctor stuff to me. But I just, I think I don't fault doctors because they weren't taught this stuff. Like, look, people say a lot of ignorant, ridiculous things, and there's no place for minimizing and dismissing people. But I try to give them the benefit of the doubt because I had the same training they did. I went to Duke, like, pretty good place to go to for training. I didn't hear anything about hypermobility, anything about dysautonomia, anything about mast cell. It was like my third year on my own where I started to figure out these things. Then I sunk casually like 5,000 hours learning about this stuff, which is like, it's not easy to do. Like you have to really want to do this stuff. And I chose this field of GI where I saw a lot of people that didn't have answers. So like I felt obligated if they were coming to me to learn this stuff. So I don't fault other doctors, but I'll say like it's not this is mast cell and compression disorders is really complex.
Yeah.
And you can't just give them a paper and be like, okay, I got it now. You kind of have to go on your own and find a doctor that already lives in this space and is passionate to figure this out. Um, I applaud usually PCPs are better than this than subspecialists, but a lot of PCPs that I work with through my patients will be like, you know what? When they hear these stories from their patients, they're like, you know what? I don't know what's going on right now, but I'm going to find the answer for you.
Yes.
That's the right answer.
Yeah.
So I guess the boiled down version is I wouldn't try to educate your doctors. It's not going to go, it's going to land on deaf ears, right? I think if I were to try to petition to them, be like, hey, look, I heard about this thing called mast cell. Is it possible what's going on with me? And do you have any idea of who I can see in your system, or can you help me look around? Like that's the way I would phrase it because asking them to just learn about mast cell with a couple papers is impossible. It's I've been reading about mast cell for like 3 years and I'm still getting my head around it, right? And so it's yeah, that's the way I would phrase it. And I hate to be doom and gloom, but I also want to
Yeah.
be realistic and not I kind of know how doctors think too.
Yeah, unfortunately, but it's so true. And this is the shared experience in this population of patients is that too hard basket, I don't want, or it doesn't exist, or, I'm not gonna bother. Um, so yeah, we really have to be fierce advocates for ourselves. But like you say, ask if there's anyone that is there anyone you can refer us to that may be able to help me with this and do your own
Yeah.
research. You know your body. I mean, prior to my diagnoses, I was slapped the label of functional neurological disorder was slapped on me. And
Mm.
I see that a lot. I bet you do
Can I
too.
share a story?
Yes, please.
Okay, this is devastating. And I'm not gonna name any specific institutions, but it's a reputable institution.
Yeah.
I had a young woman who had definitely hypermobility.
Mhm.
We were doing our visit together and she passed out like on the screen when she stood up.
Oh,
And these symptoms were diagnosed as a functional neurologic disorder.
yeah.
Drives me crazy. Went to a very reputable place where they were told, don't take any medications for this because it's not real. Or it's real, but we can't cure it. So you just have to learn coping mechanisms. So she did like cognitive behavioral therapy a couple hours a day and hypnosis and was just like, and she's like 19.
Um,
And I tested her for her mast cells and her mast cell activation came back positive. And we're like, okay, so we have something here,
yeah.
right? We have something here. And the mast cell testing doesn't always come back positive, but this is a time
Yeah.
where it's really, really helpful because I asked her up front, like, can we start some medications that I think may make you feel better? She goes, I was kind of told not to take any medications. And you're like, oh goodness, like, and I don't know if this is going to work. I wasn't totally sure that she was mast cell. Like her story was pretty suggestive of it. And thank goodness that test was positive because now her and her father are like, okay, yeah, we got something here. Like now we're rolling. We got like an objective marker to hang our hat on. Everything to date has been negative.
Yeah.
And it's just and that's why it's my heart goes out to all the people out there who are living with this and been
And how'd
going
she
to people
go?
for us. Huh?
Did she improve?
Oh, we're just getting started. Like
Okay.
we got a long road. Like diagnosing his mast cell is easy.
Yeah,
It's the
yeah, the
clinical stuff.
FND, it's just something that irks me up because, I mean, look what happens when we treat the things and remove that label, like you have a more functional human. So, yeah, I get very passionate about that diagnosis too. Oh my goodness. Okay, we have lots of questions. Do you want to pick a few that strike you specifically? We've got lots of amazing questions here. Um,
I think you know your audience the best. Like, what do you
Yeah, yeah,
think?
yeah. Oh, do you see FND in your POTS MCAS patients? That's what I was talking about. I
Yeah,
did want to
I think
highlight,
FND is I think FND is mast cell activation syndrome.
yeah,
And there's a lot of there's like PANS and PANDAS, which I'm not very familiar with because I'm not a pediatrician. Um, but I know what to look out for. But mast cell can definitely manifest a lot of neurologic conditions like
definitely.
depersonalization, like not feeling like yourself, seizures. Obviously, like POTS can lead to syncope. So all of these things need to be addressed. And
100%, 100%. Because I mean, I was diagnosed with that for a long time, and when we started treating the immune system, I was able to walk. I was out of a wheelchair. I was functioning, had two more kids, so amazing. Um, Question: what things make SIBO stick around despite rifaximin treatment? Oh, this is a big one. How long do you see it take people to resolve this, if even temporary?
I think I piss off a lot of people with my SIBO take. I don't really care about SIBO. I'm sorry. I just don't. I recognize that it exists. Can I just back up and talk about SIBO? Can you give me like a couple
Please
minutes?
do. Yeah,
So let's just talk about like what SIBO is. It's an overgrowth of bacteria in the small bowel, okay? And when that happens, it ferments food before it reaches the colon, so you get bloating, and the load of sugars that they reach is much more than when it reaches the colon, so you get a ton of bloating and distension. Okay,
Yeah.
I don't care about that. We can treat it well. The question is why is it there to begin with?
Yeah.
Okay, so because if you don't address that, it comes back. Okay, so what are the most common reasons people get SIBO that we see? One is
Chronic
like
illness.
after abdominal surgeries because you have a lot of adhesions in there and you can kind of get these like blind loops of bowel after surgeries and they just kind of become stagnant and kind of bacteria just kind of can fester there because your intestines every 90 to 120 minutes or so do this big kind of cleaning feature called the migrating motor complex. And it's not as effective when there's like a lot of adhesions in there. It just instead of being it just kind of gets tethered and kind of caught in different places. So that's a big one. Um, we see it in people who are on chronic narcotics because the bowels move not
Mhm.
very well. Diabetes, when it infects kind of the nerves and the way the small bowel propagates, um, and mast cell activation. I can't tell you why in mast cell. I don't know the chemical pathway, but we do see it a lot, and I have to think that just the mast cells really mess with the way in which the small bowel clears itself. I just see such significant rates of SIBO in those mast cell activation syndrome. And guess what happens when you treat their SIBO? Like, not a lot. Like, they may get a little bit better, but you always have to address why it's there to begin with. And so when someone has like refractory SIBO, it's not like I'm not looking for the next best thing to treat their SIBO. I'm not like looking for more herbs and more antibiotics. I'm thinking of why, how do we
Yeah.
get your bowels moving? And in this population with hypermobility and POTS and mast cell, it's usually treating the mast cell and things get better.
Do you use
So
probiotics as well? Bowel movement.
depends.
Yeah.
Depends, right? So like if someone has mast cell, I treat the mast cell. If they have other reasons to need prokinetics, like if they have a lot of dysautonomia,
Yeah.
and they don't takes a long time to poop. Someone mentioned like True Lance, I think, and we can talk about True Lance. Like True Lance is a secretagogue, so it brings in a lot of water into your intestines. It's like Miralax on TNT.
Okay.
I would have slow motility. I probably wouldn't use True Lance. It's just not really getting at what you need. You probably need a pro-motility agent like Motegrity. So Motegrity is a really nice option. For those in the States, you can get it from GoodRx for like $30. It's really nice because insurances rarely like to cover it.
What's the
Um,
active ingredient in that one? What is it called?
Precalipride, it's a 5-HT4
Okay.
agonist in the colon. Um, but like some people, benefit from like mastodon with POTS. Like that's a different. So
Yes.
it's really individualized.
Yeah.
But if someone has like I've had people who have had SIBO after gastric bypass surgery, and that's like these kind of blind loops of bowels. So sometimes I'll use Motegrity in them. But in those who have SIBO in the context of mast cell, I treat the mast cell and things usually get better.
Yeah. Yeah.
I
No, that makes
rarely, it happens. Some people really benefit from SIBO therapy. I'm not saying they don't, but by and large, focusing on the reason why they get SIBO is my opinion the way to go. And when they like look at like does SIBO cause like leaky gut and things like that? The answer is no. It's usually when people have IBS, which I think is just mast cell activation syndrome. So I think mast cell causes dysmotility and increased intestinal permeability. I don't think SIBO does. It doesn't make sense to me as to why bacteria would just cause leaky gut. I get why mast cell does. That makes
yeah.
total sense to me.
Yeah.
I don't think any data has supported it, but I think there's a lot of different thoughts in this space, and you could totally disagree with me, and I'm here for it. That's just my experience. Like I just don't. I've treated dozens and dozens and dozens of people with SIBO, and I'm just overwhelmingly underwhelmed by how it doesn't really do a whole heck of a lot unless you treat the reason why it's there to begin with.
Yeah, yeah. And on the topic of mast cell, this is I have this conversation a lot about getting a diagnosis. So Leslie has asked, do you think you need a positive tryptase test for MCAS?
Oh,
My
no,
daughter's
absolutely.
ranging from, sorry, 9.3 to 10.5 for 3 years
So
now.
those levels are definitely like eye-raising levels for tryptase for sure. But let's talk about like what tryptase is. And so
Yeah,
tryptase is a really good marker for systemic mastocytosis, which is a malignant version of mast cell activation syndrome, where there is clonal it's late proliferation of mast cells. So
yeah,
there's many mast cells and they're all mutated. Mast cell activation syndrome is where there's not more mast cells than there need to be, but they're twitchier.
Mhm.
Okay. So tryptase isn't necessarily elevated in mast cell. In fact, so it's elevated in anaphylaxis, like
Mhm.
classic anaphylaxis and systemic mastocytosis, just not a good marker for mast cell activation syndrome. And so I usually just listen to people's story because the story is like there's nothing
Yeah.
that behaves. I'm sorry. Like young
So,
women, sometimes bendy, sometimes potsy, and
yeah,
has migraines, brain fog, fatigue, reflux, bloating, allergies, joint pains, back pain. Like what
all the
endometriosis? Like
things.
what does that? What does that? Nothing does that, right?
Yeah.
And so if you can tell me one other thing in medicine that does that, I will give you $1 million because there's nothing out there. And so it's usually the story. And then I will order some biomarkers because I do like to do some clinical research and just like, I like to see how many people have biomarkers and which people have which positive biomarkers. And I think that's helpful just to kind of push the field and get more data, but it doesn't change the way that I approach patient care.
Interesting. And also, correct me if I'm wrong, please, but tryptase levels settle pretty quickly after an episode, don't they? So it's like, oh, we're gonna run and get your blood test like within an hour of like a big flare. Um, it's
Ridiculous.
and
And if you go to like Quest or LabCorp, or like Quest and LabCorp are some of the private companies where you can get labs in the States,
yeah,
and you need an appointment. I don't think you can just be like, I feel
you
like
can't just
crap.
walk
I'm gonna
in.
run down the street. Like, that's not how the world works. And so I think there's, as you mentioned, like significant logistical challenges of pulling that off too.
Yeah, yeah. So, and you said those are kind of pushing higher ranges anyway. So, yeah. All right. Question. Any advice you have on how to get through to patients who have severe MCAS and dysautonomia on the nervous system piece? Specifically, patients of mine that come to mind are those who are deeply entrenched in the medical system, tons of medical appointments, polypharmacy, and are very focused on the medical piece and meds and the workup and aren't super receptive to the nervous system part. I think if you have dysautonomia and MCAS, you have to, yeah, I mean, even from a pure medical perspective, like you can't disregard the role of the nervous system in all of this. Um, you just have to
Yeah,
kind of, you
no,
just
100%. Yeah,
you
I
just have
mean,
to tell them. I mean, dysautonomia is autonomic nervous system dysfunction. Regardless of how entrenched they are in, polypharmacy and medical appointments, as we said earlier, you need to get at least the basics, focus on some of the basics because that's going to support the nervous system. Even sleep. Sleep is so big and so important.
yeah, I will say though that you got to meet a patient where they are though, right? You can't force them to do something that they don't want to do.
Yeah.
And so I would try to figure out why they're so fixated on it. Do they just want to, do they just want like a positive test to show up? Some people just want a positive test,
Mm,
right? To be like, this validates my experience. Is it like, do they really just want some people just really want medications, right? And so, right, you can't force people to do limbic retraining if they don't want to do it. And so I think you have to, I think, yeah, your goal is to educate, 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 and then maintain a long relationship with them. Like some people I don't get through for like 6 months, right?
yeah.
Where you're just like, I'm here for you. I don't really get where you're coming from. I don't think you get where I'm coming from. Like we are not on the same page, right?
Yeah.
Because I have my agenda and they have their agenda. And sometimes that doesn't align. And I try to do my best to meet them where they are, but I bring all my preconceived notions on how patient care should work and things to do. But I would, as opposed to like clearly, I love the way that you're thinking, Natalie. Like that's exactly what you want to do and approach this from a whole body kind of perspective as opposed to being like, I'm not just treating mast cell, I'm treating this person with mast cell. So we need to
Yeah.
figure out their nervous system regulation. That's such a good way to do it. But I think you gotta do some legwork to figure out why they're coming from that perspective. Because when medical plans don't go well, it's because the doctor couldn't see where the patient comes from. And sometimes it's really tough because there's layers and layers of medical PTSD and trauma and distrust
Yeah.
and like sometimes it
Oh,
just takes time to weed through that and you're like 6 months in, you're like, we haven't done anything right, have we? Like what am I missing here? And so, it's tough to force someone's hand to do something, but I think, yeah, I'd start with trying to get a sense of why they're so insistent upon doing things that way and
yeah.
trying to meet them in the middle somewhere. It's tough to do, but
Right.
yeah.
And from my perspective as a naturopath and from a functional medicine perspective, if they're already open to polypharmacy, talk to them because obviously nervous system herbal medicines that work on the nervous system can work very effectively too. Um, so if they're open to taking herbs, there are herbs that you can use to kind of help them if you see that the nervous system is like a point where they're really stuck and you really want to shift this to see breakthrough in other areas of their healing. Like you said, they've got severe MCAS, severe dysautonomia. They're already on lots of medications. If they're open to taking more things, I'd just be like, well, this will help with some of that nervous system stuff, whether it be, a lot of the stuff that we see is this HPA dysregulation. Your adrenals are fried, your cortisol's maybe flatlined, your adrenaline is through the roof, especially if you've got POTS and you're like yo-yoing. Um, so yeah, I mean, that's me from my naturopathic perspective. We've got great tools, nutrients also.
Yeah.
Um,
I mean, I'm
yeah,
not gonna lie. I use benzos sometimes.
well, yeah, there
Like
you go.
out of any Klonopin, like they have receptors on mast cells too. Like when you're in a
Yeah,
mast cell flare, a little Klonopin can go a long way. Do I love it? No, but it's a tool. And I
yeah,
know L-theanine
yep.
is a mast cell stabilizer. I think ashwagandha. I'm just naming
Yeah,
things like
it's
ashwagandha is
more.
probably.
Yeah, it's
I'm just
more for your adrenals, but it can lower cortisol too much too if someone's already like burnt out. There are adaptogenic adrenal tonics that are a little bit more stimulating, but not too stimulating that won't cause your cortisol to drop too low. So yeah, there are lots of options if it's, yeah, but L-theanine I do love. Magnesium, great. Also great if their bowels aren't moving. But all right, should we pick two more?
sure.
All
You
right.
want to do gastric? I have a gastric
Uh,
stimulator question. Is that?
Oh, hang on. Where are we? Oh my goodness.
I'm Lauren Ramisi. Sorry if I
Got it.
pronounced your.
Yeah, got it.
No, no, that's no wrong one. Sorry, my brain is fried. Uh, where did I see this? This is a diverticulitis one.
With
Leslie Garrick is a gastric stimulator.
will a gastric stimulator help or hurt
And
teens
I
with?
kind of want to say this because I want to prevent them from getting a gastric stimulator.
I don't, that's not, I have no idea about gastric stimulators, so please take it away.
All right, so yeah, I'd be worried, Leslie, about a gastric stimulator in your daughter. So uh, a lot of people with POTS have a slow-moving stomach, right?
Mhm.
And gastroparesis, and it's not uncommon. And so one is to make sure that her symptoms are due to gastroparesis, which is just kind of this like, ugh, like kind of get full early. Generally can tolerate liquids, not so much like fatty foods, fibrous foods. Some nausea and vomiting as well. Usually not pain. Just make sure that 'cause a lot of people have delayed gastric emptying on a gastric emptying study, but their symptoms aren't due to gastroparesis.
Mm.
Okay, so say her symptoms are due to gastroparesis. Okay, what symptoms get better with a stimulator? So stimulators don't make the stomach empty any faster. They help with neuromodulation. So they change the way that the afferent nerves communicating signals from the gut to the brain are signaling. So for people who get like a lot of um, like nausea after eating due to gastroparesis, like it can help with that. Here's the rub, is that with mast cell, I worry about a gastric stimulator.
Hmm.
People with mast cell typically don't like implants in their body or anything for it. Right? For example, there is a whole group of folks that get their gallbladder taken out and have more pain even after they get their gallbladder taken out because that stupid little clip left behind. Okay.
Yeah.
So a gastric stimulator, albeit it can be removed, it's just a foreign object and I worry about it. Compounded by the fact that a gastric stimulator only will work for the stomach, right? So if you have dysautonomia, you're also going to have small bowel dysmotility as well, right? And so I'm just not I'd have a lot of questions. And as someone who believes in gastric stimulators, I think they're a great tool for the right person. In the dysautonomia mast cell patient population, I'd be really, really worried. And it's just not, it hasn't been well studied.
Can you take them out? Or are they
Yeah,
permanent? You
you
can?
can, but it's not small. It's not like it's a surgery, right?
Yeah. Yeah.
It's not even an endoscopic. It's more it's an open surgery. And so if you subject
Wow.
someone with mast cell, with hypermobility to a surgery, like that's a big deal. You flare more, right? Like all the
Yeah.
crap in the hospital, the pain medications, the anesthesia, the
Oh,
smells, the stuff, like the travel, like it's not a
definitely.
small deal. So
Yeah.
I'd use immunotherapy over a stimulator first, right? Like IVIG. I mean, that's obviously, I kind of wish I reeled back that comment a little bit, but you think of like, why is someone's stomach not moving very well? Like, and
Yeah.
with dysautonomia, it's more of an autoimmune process. And so that's where I'd use more immunotherapy than anything else. But that's a loaded question. I just kind of applied a blanket statement to your daughter. I wouldn't kind of run with that, but I would be worried about a stimulator.
Yeah. Oh no, that's really good, especially in someone so young, um, to have to go through something. So, I mean, if it's necessary, it's necessary, but if it can be avoided, that would be amazing.
Sounds
I,
like it sounds like they're really trying to find answers, right?
yeah,
And so I don't want to poo-poo what you got going on or yuck your yum, whatever you want to say, but I worry about it. But it could be the right thing. I don't know. It just hasn't been well studied. And so I think my gut tells me it wouldn't be where I would start. But I'm sure you guys have done a lot. Um, I'm sorry you guys are going through that. It sounds like it's really tough.
yeah, yeah. I have one more question for you. Is it common
Yeah.
to have MCAS with absolutely zero typical allergy symptoms?
Oh, yeah. The GI mastocytosis.
Yeah.
That's
But does
I
it
have
have
a
to be mastocytosis?
No, I call it that. I just call it
Oh,
like GI
okay.
mastitis. So yeah, so it's a little bit of a misnomer. I probably should have said that, but yeah, I have some people who just have like profound bloating or microscopic colitis or just GI symptoms without the classic allergy type symptoms. That's yeah, but
Interesting.
there are hints. There are hints though, right? So here's some subtle hints. Okay, extreme sensitivity to smells,
Hmm.
sensitivity to medications, subtle hypermobility like TMJ, past medical history of endometriosis, like that aren't like classic mast cell features where you have all the sinus allergy stuff, but like stuff that travels alongside mast cell, right? An extreme intolerance of alcohol, right?
Yes.
So like these are questions that I asked to be like, is there something else going on here? And I have one young woman who gets horrendously bloated. Um, and hasn't responded to anything. And I'm like, okay, well, you haven't responded to anything, then maybe this is mast cell, and she tested positive. And that's a really that's tough. But yes, so there are people that have primary GI mast cell disorders, I'm sorry, symptoms associated with mast cell activation.
Mhm.
Um, but yeah, everybody's different. It just
Yeah.
takes a high incidence of suspicion.
And then there's also like the neuropsychiatric side
Yeah,
too, like
yeah,
the
100%.
anxiety and then the cardiovascular. So yeah,
Chronic
it's
nausea.
yeah,
Hmm.
very
Yeah.
interesting. I
Let me
just
talk, let me answer Susan's point real quick. So what
yeah,
tests did you ask for? So
yes.
again, I don't want to like say testing isn't it. I mean, I always order testing, but I don't even if it's negative. So the sensitivity is about 35%. So it's less than a coin flip as to whether you're going to test positive. And I'll tell you why. So the mediators of mast cell are what we're looking for. They last in the body for like 5 minutes. Okay. So
Yeah.
they're gone in a flash. So, there's a 24-hour urine study, leukotriene E4 pr 2,3-diner prostaglandin F2 alpha and N-methylhistamine are
Mhm.
probably the three most sensitive ones. Plasma histamine isn't too bad either. And the 24-hour urine collections are nice because you get data over 24-hour periods. So you're not basing this test on like one data point in time. It needs to be kept cold though,
Mhm.
and it also depends on how good your lab is, right? And so I give my patients like something to bring to LabCorp Quest to be like, please keep this cold. I guarantee you they just throw it in the trash. So it also depends on whether the lab decides to do the right thing. And if they leave the jug of urine on the counter for too long, it's gone, right? And so sometimes a negative test is reflective of how quickly the mediators hang around, or the courier taking too long. So Susan's testing were normal. If your clinical symptoms fit, then I just treat you for it, as opposed to basing my decision making off testing. There are times where like people have very atypical symptoms where it is really nice to have those testing because there are times where I'm like, you've had all the other tests and this goodness could be mast cell. I've never heard a story like this before. And I'll be honest, that like that's where testing is helpful. But sorry, Susan. I'm sorry it was negative. I wish it were positive for you.
Yeah, and you can just go for it and treat it, right? And if they respond well, that's great. Um, so yeah, I mean, testing is always tricky, and then you speak to immunologists who are like, no, no mast cell activation. It's not, you don't have this crazy high tryptase, and then you end up like in back at zero. So yeah, I say to people, just treat it and see what happens.
Yeah.
But there are so many more questions I'd love to talk to you about, things that I love talking about, like chronic pelvic pain, endo, adeno, food sensitivities, your microbiome, so on and so forth. But I could go on and on for days, but we're gonna wrap it up here. It's late. Dr. Zac, thank you so much for jumping on. So grateful for your time. I think that um, everyone else that's here with me is incredibly grateful that you've taken the time for us tonight to, let us pick your brain. Thank you so much for everything that you do for our community. And yeah, everyone can find you over at Instagram. What was your handle again, Dr. Zac?
Dr. Zac Spiritos. Very
Dr.
original.
Yeah, and I'm endo naturopath. So thank you so much, everyone. Have a good night or good morning, evening, afternoon, wherever you are. Take care, and yeah, let's keep raising awareness for dysautonomia. Happy Dysautonomia Awareness Month. Take care.
Thanks so
See
much,
ya.
Kim. Nice to meet you.